Top Med Talk.
Well, hello and welcome to Top Med Talk. I'm Desiree Chappell, and I'm joined by our editor-in-chief, Monty Mythen in London, England. Hello, Monty.
Hi, Desiree. Good to be here. How are you today?
It is. I'm doing very well. Still in the midst of COVID, but managing okay. And it's, been about a month and a half since we've been doing our almost daily updates and conversations with people around the world about COVID from the front lines. We're going to be continuing to do that. But Monty, we thought we'd mix it up a little bit today, didn't we?
Yeah, I think there's a bit of COVID fatigue creeping in various different places and the hope that things are starting to calm down a little bit and life might be going back to normal. We certainly haven't lifted the lockdown here, but the conversation is very much about what lifting the lockdown will look like. And as we've shared, we started scheduled surgery in London a number of weeks ago now. And the next question is when we might start what's traditionally being called elective surgery. When will we get back to doing the things that can wait a little bit longer?
And Monty, for our listeners who don't know the difference between schedule and elective?
So in other words, it's people have different categories. We all understand the urgent one. That's the can't wait. The scheduled is the one that can wait a little bit, maybe up to about 20 or 30 days. And that would commonly include, for example, the cancer surgeries that are deemed to be more urgent. And elective is it can wait a long time, which might be something like an elective knee replacement unless the pain is intolerable. Those are three broad categories that we work with here.
Yeah. Well, Monty, I think we're still going to be taking care of COVID patients for a while, especially as the world starts to open back again. I'm sure we'll start to see a little bit of a resurgence. So we're still going to be having to care for COVID patients, but we are getting back to life as normal. We thought we would go ahead and chat with one of our key partners, the Perioperative Quality Initiative, to discuss their recent published article in the journal Perioperative Medicine. Now, full disclosure, we are both authors on that paper.
we are, which I think, is that a first for us? I mean, we've spoken about a lot of papers, but I think this is the first one we're co-authors on it. We're privileged to be. And
we have the lead author as well as Tim Miller, who is heading up the Perioperative Quality Initiative with us today. So a fan fave on Top Med Talk, Dr. Tim Miller from Duke University. Hello, Tim.
Hi, Desiree. How are you?
I'm doing well. Thank you very much. How are you faring down there at Duke?
Pretty good. Pretty good. I mean, same as everywhere. Hopefully over our peak. We've not had it as COVID has not been as bad down here as many places. We haven't got the population density, and we've obviously had a number of patients, and we're just starting to decrease and starting to talk about ramping up our scheduled / elective surgery, as you were talking about.
Do you feel that you guys are going to jump right in, or have you already started prepping patients and getting ready in that way?
Yeah, I think everyone's been very happy with the way the hospitals handled it, and the state, to be fair. Obviously, we haven't had the surge, and some places have, and we were a little bit later, perhaps, so we had a bit more time to prepare. But we're doing some surgery that needs to be done within 30 days. And as of about 3 weeks ago, every patient coming for surgery is being tested. We now have a test that our pre-op clinic orders, and all patients get it. It comes back within 4 to 6 hours. And we also have the 15-minute test. So any leveled patient is getting the 15-minute test. So we're testing everyone, and we're ready to start slowly increasing surgery, starting with some of the patients that have been delayed that are now deemed to need their surgery in the next couple of weeks. So as of next Monday, we're probably going to go up by another sort of 20% in our scheduled surgery.
Any surprises in there, Tim? Any asymptomatic people who've tested positive? If you're allowed to share that.
Yeah, I think I am. Actually, pleasantly surprised in many ways, because it's probably one of the largest cohorts, at least around here, of asymptomatic patients. And last time I'd heard, we tested around 1,500. I'm sure it's more now because this is over a week ago. I think there were 4 or 5 positive. And some of those, I don't know the exact details, were from nursing homes. So even though they were asymptomatic, they were high-risk patients. So the actual prevalence of asymptomatic disease in the community is not great here, and we really had no idea beforehand. Some people were saying, would it be 10%, 20%? It's definitely not here. It's significantly less than 1%.
Our second guest today is the lead author on the paper that was published in the journal Perioperative Medicine. We have Greg Martin from Emory University. Hello, Greg.
Hi, Desiree. Nice to hear from you.
It is good to hear from you. The last time we chatted was right after the POQI conference, where we did a pretty deep dive on what we had discussed over the weekend. Can you, for our listeners, give us a little bit about your background first, because I didn't ask you that. What do you do there at Emory?
I'm a pulmonary and critical care physician at Emory University. I work mostly in the ICUs, but I take care of some pulmonary patients as well. And to this discussion about COVID, we've certainly seen that in Atlanta. It's been a bit of a roller coaster for us. We didn't have anything near what they've experienced in Italy or even in New York, but we've certainly seen a lot of cases. We also shut down all of our elective and non-urgent surgeries, and repurposed a lot of our spaces and expanded our ICU capacity to handle that.
Yeah, I thought Atlanta was a bit of a hot spot, or Georgia in, I guess Albany was.
Yeah, there have been a few hot spots around Georgia. Atlanta has been one of them just because of the density of the population, but the other has been a lot of care facilities, some of them nursing care facilities around Atlanta. And then we've had a few other hot spots in small towns in South Georgia and other places that have been a little bit surprising because they weren't anticipated. And once the cases were discovered, then they realized, as Tim was just saying, once you begin testing, you find a lot more people. And we were unfortunate in that way that it spreads, particularly in healthcare institutions, quite quickly.
Well, Greg, we participated in the Perioperative Quality Initiative, and it was POQI 5, right, Tim? That was...
Yes, POQI 5.
Yeah, POQI 5. And it was the title of the paper that was published was The Perioperative Quality Initiative Consensus Statement on Fundamental Concepts in Perioperative Fluid Management, Fluid Responsiveness, and Venous Capacitance. So it's a pretty...
We wanted to have a title that was a real grabber for the audience.
Yeah.
Make you want to page through it in detail.
Yeah, exactly. And it's turned out it's purely coincidental that it's come out at the moment, but it's a pretty hot topic right now because of the classical debates about fluid management in the context of acute lung injury. It wasn't actually written for to be deployed mainly in that context, but it's every discussion we've had about COVID-19 has included the wet, dry, something else, all that language that's confusing.
Tim, for our listeners, what is POQI? What is it that they do and the method that they use on these POQI conferences?
Yeah, so the Perioperative Quality Initiative was formed around 4 years ago now. Really, the idea was to do some consensus conferences around this emerging specialty of perioperative medicine. And the methodology is a sort of modified Delphi approach. Really, the idea is to get a group of experts in a room to debate a subject and come up with some consensus statements. And typically we have 2 to 4 different groups. And the way the conference will work is that individual work group will sit down in a room for an hour or two, come up with some key questions, some consensus statements, maybe some figures, the way they'd like to present their material. And then each group then goes back to the plenary session and they present this at the plenary. Each group takes a turn to present and they get criticized, discussion, ideas of how things could be improved. And basically over the course of the 2 or 3 day conference, you go back and forth between your small work groups and the plenary groups until you get consensus around concepts and statements that can be published. And the idea behind this particular POQI was that we thought, it's a good idea to revisit some physiological principles and try and make it practical for the everyday clinician. It's often a while since some of us have read about physiological principles, and some things have changed and evolved. So to try and do a sort of practical POQI style paper about physiological principles. So that was the idea, and Greg was kind enough to lead this group, and I think we come up with a very nice paper.
So like I said before, Greg and I and Nate Shapiro, I believe in Mike Grocott, right after the POQI conference, were able to sit down and do a deep dive and really get into some of the questions and the statements that we came up with, really into fluid responsiveness and venous capacitance, which was interesting. And I'll signpost our listeners, we will definitely be putting that in our show notes. So have a listen to that, because today I think we're going to try and do more of a brief skim of the article, and maybe not so much into the weeds of, one of our favorite topics, stressed and unstressed volumes and things, things like that. But I'll just ask you, Greg, for you personally, what were some of the big takeaways for you?
There's a couple of them that really that came out for me. The first one is that we need to begin thinking about more individualized fluid management. We've certainly learned more about the physiologic principles that go behind it, but we sort of want to think about them particularly for each individual. And we stated the goal in this case, in this paper, that the fluid therapy is really there to try and enable or normalize cellular function so that tissues and organs can function normally. And therefore, if you're a perioperative patient, you're going to prevent complications. If you're critically ill or acutely ill, it's going to help mitigate that or help the system to recover and repair. But then the second part of that, how do you choose the optimal fluid volume, is a very individualized decision. And part of the deep dive on venous capacitance and other things was really trying to understand that evolving concept and make sure that we can think about it for clinical relevance and how do we apply that in an individual patient.
Monty, we were looking at the paper earlier and talking about individualizing the patient's own fluid needs. And you were saying that you really enjoyed the tables from the article here.
Yeah, and I mean the diagrams are always fantastic, but I'd kind of forgotten with the passage of time when you do these things is that the amount of energy and effort that went into the terminology, because in trying to individualize the management, our bedside terminology is sometimes sloppy. We confuse hydration with volume status, and then we are talking about total body water when we mean volume status. So I think those tables are really worth people having a look at closely and reconsidering when they use their language. I'm much more meticulous these days when I'm teaching about differentiating the concept of hydration, for example, total body water, and left ventricular end diastolic volume and the concept of responsiveness. So often you have to reread these papers to remind yourself how much good work was done on the days. Greg, you must be very proud of it.
There's two tables in there, one on terminology that's more physiologic and one that's more clinical. And part of the reason that they're there is that this Delphi group and the people working together realized as we were talking that we didn't all use the same language, that we were saying things and we didn't always mean the same thing when we were using terms. And so we realized that was almost certainly common around the world, and we needed to put it down in text and make sure everyone's on the same page.
I think it's for people who are reading this manuscript. I mean, you could read the entire manuscript. I think it's 12 pages, but if you wanted to dip into it, there's some consensus statements at the start over the first couple of pages, just highlighting what we talked about during the conference. And then as Monty mentioned, there's those two very relevant tables and a number of figures. So even just looking at those, I think you could get a lot out of this manuscript just revisiting some of these key concepts.
And then there's the concept of fluid responsiveness, and there's a table one is the summary of the methods for predicting fluid responsiveness. And it gives the method with a key reference, it gives the threshold levels and also the main limitations. And again, with the reference point of COVID-19, there's been a lot of discussion about this recently, because traditionally, more recently with, let's call it classical modern ARDS, the stiff lung, and the tendency for people to want to avoid fluid excess, there's been some nervousness, particularly in younger clinicians, in giving fluid. Whereas here we're seeing patients with possibly more compliant lungs where there's more of a perfusion challenge than there is a ventilation challenge. And we've heard a lot talked about the passive leg raise, for example, where they can perform, there's a nice diagram in the paper, this passive leg raise to give a fluid bolus physiologically without giving extra fluid. And, if the hemodynamics improve, and, by the way, the saturations get better because you improve, lung perfusion, then, it's okay to go ahead and give a fluid bolus.
What's your take on that, Greg? As a pulmonologist, you must have a natural tendency to want to keep the lungs dry.
Yeah, it's one of the things that ARDS is one of those things that I've spent a good chunk of my career on, and particularly fluid management in ARDS has been a big part of what I've tried to study, either ways to prevent fluid from accumulating in the lungs or ways to try and accelerate drying out the lung and helping it to recover. And of all the things that we talk about, a lot of the things like Monty was just saying, ways to predict fluid responsiveness, the more that you can do that, minimally invasively and without any risk to the patient is probably the easiest. And I've often joked in the past that the passive leg raise is the easiest because it just takes a medical student to stand at the bedside and raise the legs. But the diagram in the paper is really nice because it basically shows a patient going from a typical, what you'd see is a patient sitting with their head up and just reversing that. So the head goes down and the feet go up, and doing that's pretty simple. One of the caveats that I always tell people is you can't just rely on the blood pressure for that you really want to see stroke volume or cardiac output changing, because you could certainly make someone uncomfortable or do something else that raises blood pressure. And that's not necessarily a positive hemodynamic response. But from a critical care and an ARDS perspective, being able to test someone's fluid responsiveness without actually giving them fluids or putting them at risk of more pulmonary edema is incredibly valuable.
We know that, the way that we're ventilating these patients, specifically if people are following kind of those ARDS recommendations and still doing, high PEEP, low tidal volumes, those kind of things, what are some of the limitations when we're looking at utilizing the dynamic parameters that we were mentioning in the paper and the passive leg raise and fluid challenges? Greg, do you want to take that one?
One of the things we realize is that dynamic measures of cardiac output and stroke volume are much more useful than static measures. So particularly years ago, we used to talk about using things like central venous pressure as maybe a measure of intravascular volume or of fluid responsiveness, and we realized that that's simply not the case. And so now we have many devices and techniques for more dynamic measures, meaning you can track over time stroke volume variation or pulse pressure variation and see those things change. And those can be pretty good, not perfect, but pretty good predictors of whether someone will respond to a fluid challenge. And one of the things that we did, and its second page of the manuscript has all these summary recommendations. And part of what we did in the consensus process was try and nail down things that people could take home and use. So one of them, for instance, is how do we define fluid responsiveness and fluid challenge? And we said that fluid responsiveness can be tested by administering 250 to 500 cc's of crystalloid, ideally in less than 15 minutes. So it's administered quickly enough that the patient can respond and you can make a measurement. And what you want to see is a 10 to 15% increase in stroke volume. And doing all those things by giving fluid is great because you can look at actual changes in cardiac output. But like we were just saying, if you do it with something like passive leg raise, where you're redistributing fluid from the lower legs up to the thorax, you're getting that same preload challenge, but you're not actually administering fluids that could cause problems for the patient who has ARDS or chronic kidney disease or some form of heart failure.
All right. Are there any other points that we want to highlight in this?
The other one that I would talk about is we also talked about different ways to evaluate patients, and again, more individually. So we talked about sonographic evaluation of patients, looking at IVC distensibility and cardiac function. And particularly in the era of COVID-19, that's become more and more important because we use a lot of bedside ultrasound and even POCUS or point of care ultrasound. And for us, that's been incredibly valuable because we don't necessarily have or want to do additional procedures on patients. We try and particularly minimize aerosol generating procedures like bronchoscopy and airway procedures. But even other things, we try and group them all together and minimize healthcare worker exposure. But when you're in the room, you can do a quick ultrasound and get a very good sense of what's going on with the patient's cardiac function, which is not, unfortunately, probably is having some abnormality in 10 to 25% of COVID-19 patients in the ICU. But it also gives us a much better sense of their fluid status and whether they might respond to a fluid challenge.
Absolutely. The POQI work, Tim, is all open access, isn't it? You can go to the POQI website and download all the previous manuscripts, and the diagrams that go with it are deliberately open source. Is that correct?
Yeah, absolutely. It's available on the POQI website. Also, Perioperative Medicine Journal is an open access journal as well. So the manuscript is available on that website. And as you say, all the figures are owned by POQI and they're available for use if folks want to use them in other manuscripts or publications, etc. That's one of the things that we were very keen to do when we set up POQI.
And this is one of a pair of articles. Where's the other half?
The other one's on Professor Grocott's desk. But
I'm not calling anyone else.
It's in the final stages, and hopefully will be coming out soon.
Yeah,
we did have, which we'll post as well, another conversation with Tom Woodcock and Manu Malbrain. Monty did right right after the conference. So that'll be a good one to kind of, if you want the teaser for the paper.
Yeah, it's the bit, there was some real mind-bending stuff in there about how traditional thoughts about how fluid gets in and out of the vessels in the body and the role of lymphatics. Very, very important stuff. So we look forward to getting that out there. Big shout out for Mike Grocott. Been very busy at the moment.
Yeah.
On, he's national TV.
National TV star over there in England.
I've seen some photos. I haven't seen him on the BBC, but he's obviously been doing a fair amount.
BBC, Sky. I don't think he's done CNN yet, but he's been almost 3-4 times a day. He's explaining why it's all going to be okay.
I've seen his hair getting wilder every time I see him.
It is. Well, gentlemen, thank you so much for joining us on Top Men Talk to discuss this really relevant piece on the fundamental concepts in perioperative fluid management, fluid responsiveness, and venous capacitance. I think that it will definitely be something that we can use as a resource going forward in the care of the COVID patient and hopefully just in everyday use. So thank you very much.
Top Med Talk.
And thank you for listening to Top Med Talk. If you want more information, you can go to topmedtalk.com. We have all of our podcasts there. You can also find us on social media, Twitter, Facebook, LinkedIn. And if you want to contact us with any questions or comments, contact at topmedtalk.com. Thanks so much for listening. Stay safe and stay well.
Top Med Talk is proud to thank its sponsors, specifically Edwards Life Sciences, for their generous support through this global crisis.